Well, hello and welcome once again to this month's podcast. And as ever, I'm going to try and bring you up to date with the very latest data in the wonderful world of rheumatoid arthritis. Now, in this episode, I'm going to review two papers. The first is by Hernández et al. And identifies clinical and demographic factors associated with upadacitinib treatment persistence. It also assesses how the cardiovascular risk minimization measures recommended by international regulatory agencies impact upadacitinib prescription patterns? Quite an interesting question. And then the second paper comes from Nozaki and colleagues and evaluates the clinical efficacy and continuation rates. Efficacy, continuation rates of JAK inhibitors and TNF inhibitors in RA patients with poor prognosis factors. Now, as ever, if you want to access the summary slides, the papers, abstracts, and a whole range of incredible material, head across to imidforum.com. Imidforums, all one word.com. Okay, and you're going to find, as I say, lots of really useful information there. Well, let me turn to the first paper, real-world data on treatment persistence and measures to minimize cardiovascular risk in rheumatic disease patients using upadacitinib. Well, listen, there are a whole range of JAK inhibitors approved for use across a range of immune diseases. And this is a study which has certainly brought once again to the fore the concerns we have about, are these durable therapeutics and how do we minimize cardiovascular risk? The latter, of course, coming from the previous oral surveillance study. Now, recent clinical practice studies have analyzed the factors influencing upadacitinib persistence and the influence of prior biologic treatment failures on long-term retention. But we don't think that that latter has been sufficiently well investigated and led to the current study being performed. The FDA and the EMA recommend cautious use of all JAK inhibitors, and that's because of the perceived increased risk of cardiovascular disease and malignancy. And they've introduced risk minimization strategies, particularly for patients with high cardiovascular risk a priori. Now, the impact of these recommendations and prescribing patterns, as well as the extent to which they've been adopted in routine practice, is pretty unclear. And Hernández et al. First identified clinical and demographic factors associated with upadacitinib persistence in routine clinical practice. And secondly, they assessed how the CVR minimization measures recommended by international regulators impacted these prescription patterns. Okay, well, what were the results of the paper? Well, after applying Cox regression with forward-walled variable selection and considering disease duration, high disease activity, lines of treatment and previous use of TNF inhibitors, JAK inhibitors or IL-6 receptor inhibitors, only the previous use of an IL-6 receptor inhibitor was associated with significantly lower upadacitinib persistence. Okay, we can think about why that might have been later on. Secondly, clinical decisions to minimize cardiovascular risk in the upadacitinib-treated patients were guided by evidence-based findings rather than purely by regulatory recommendations. There was a significant reduction in the proportion of patients with moderate to high cardiovascular risk who started upadacitinib as compared with a TNF inhibitor from February 2022 onwards, which is kind of intuitive. And disease activity indices showed significant improvements over 3 years. From February 2022, patients initiating upadacitinib exhibited a significantly lower basal cardiovascular risk compared with those beginning a TNF inhibitor. So there's a kind of yin-yang effect. There's been some kind of impact of the regulators' advices. So the conclusions the authors draw here, well, in a real-world setting, the persistence of upadacitinib treatment is similar for patients with RA and spondyloarthropathy, but was lower for RA patients previously treated with an IL-6 receptor inhibitor. If you think about the broad range of cytokine inhibition that JAK inhibitors manifest, it could be that the effects on IL-6 receptor signaling, which are direct, as opposed to TNF-mediated effects, which are indirect for JAK inhibitors, there might be something in that, and that needs further exploration. Upadacitinib has proven efficacy in treating both axial and peripheral inflammatory manifestations of rheumatic diseases for which it's indicated. And this aligns with the results from randomized controlled trials, so no great surprise there. And it does look as if there's been some impact to minimize cardiovascular risk in those patients selected for upadacitinib treatment. So I think we need more information here. I think we need more information on prescribing patterns, but we also need more impact of regulatory and black box warnings on how people actually perform in the use of these medicines in the real world. So we'll be looking forward to that in due course. Okay, well, what's the second paper? Clinical efficacy of JAK inhibitors for rheumatoid arthritis patients with poor prognosis factors. So this is the ANSWER cohort study, answer as in answer to a question. Well, the background here is, of course, we know that biologic DMARDs, targeted synthetic DMARDs, particularly JAK inhibitors, have overall improved the treatment of rheumatoid. And we, however, still have a significant proportion of our rheumatoid patients who don't achieve sustained remission. EULAR, for example, recommends early treatment escalation in patients who don't achieve at least a 50% or more improvement within 3 months. So we've got these aggressive treat-to-target strategies, but we still have patients who struggle. So Nozaki and colleagues evaluated the clinical efficacy and continuation rates of JAK inhibitors and TNF inhibitors in RA patients with poor prognosis factors. So poor prognosis factors were analyzed separately from those in patients who didn't, and they arbitrarily chose 4 poor prognosis factors as the cutoff point, and they used real-world evidence. And the data that they report are pretty much as follows. RA patients with 4 poor prognosis factors, that's ACPA or rheumatoid factor positivity, CRP greater than or equal to 0.6 mg per deciliter, CDAI greater than or equal to 22, and HAQ disability index of greater than or equal to 0.5. Now, these patients were all at a greater risk of joint destruction than those with fewer poor prognosis factors. So that tells us that they were poor prognosis factors. The data reported here indicate that JAK inhibitor treatment was associated with a significantly higher continuation rate compared with TNF inhibitor treatment in the longer term. Also, treatment with JAK inhibitors compared with TNF inhibitors offered higher continuation rates and potentially better disease control in those high-risk RA patients, particularly those with ACPA positivity. They also enabled, JAK inhibitors, I should say, enabled faster GC glucocorticoid tapering. Amongst the 4 poor prognostic factors, JAK inhibitor treatment facilitated a greater, but note this was non-significant, reduction in glucocorticoid dosage over time compared with TNF inhibitors. Well, what do we conclude here? Well, first of all, this is not a controlled trial. And I think we need to be very careful that we don't overcall the significance of these data. But it would appear, at least from the author's perspective, that JAK inhibitors offer higher continuation rates and better disease control in high-risk RA patients compared with TNF inhibitors, particularly patients who are ACPA positive. There may also be an impact on requirement for glucocorticoids. But we do have to factor that in against the counter challenge we face, which is that JAK inhibitors at the moment have a black box warning for their use around cardiovascular risk and cancer risk. Those in turn are also related at one level at least to disease activity. So again, another volume of real world evidence that we add to the gathering evidence base, which when we take it all into account, leaves us, I'm afraid, simply sticking to the regulatory advices for the use of these medicines in practice. Well, I hope those were interesting papers for you. The full publications were uploaded this month to imedforum.com. And as I've said already, there's lots of podcasts and other information resources, really helpful summary abstracts of the papers. And it is a really quick way of just keeping yourself up to date. And as ever, don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel to make sure you don't miss our podcasts in future. How dare you think of such a thing? These are not podcasts to be missed. Well, anyway, as always, please let us know what you think by leaving a review. Thanks for your attention. I sincerely hope that this information is useful to you in improving the outcomes for the people that really matter, as our patients. Thank you so much.